So when the abnormal cells occupy about lower two-thirds of the epithelium, that's what you call CIN2. Then when the whole layer of the epithelium is affected, that's what you call the CIN3. Then when these abnormal cells break through the basement membrane and go into the stroma, that's when you are going to say you have invasive cervical cancer. So basically, there are three things that we have discussed here. You have CIN1. CIN1, that's what you call a low-grade region or low risk. CIN1 is low risk, whereas CIN2 and CIN3, these are high risk. CIN2 and CIN3, they are high risk. So immediately these abnormal cells break through the basement membrane, you call it invasive cancer. Therefore, the treatment that you need is more advanced and more expensive, as we'll describe later on. So briefly, what are the symptoms of cervical cancer? I think you may wish to know that most of the patients that have cervical cancer in the early stages are asymptomatic. They will not know that they have cervical cancer. By the time they're becoming symptomatic, then the cervical cancer would have advanced. And what are the symptoms? You have, the first one usually is abnormal vaginal discharge, which sometimes can be foul smelling if there's some infection. Then you have abnormal vaginal bleeding, which could be intermenstrual bleeding, or it could be postcoital bleeding. The other one later on is pain in the pelvis, or the pain can occur during sexual intercourse, which you call dyspareunia. Then there can be other symptoms such as fatigue, nausea, or weight loss. Then I'll take you through the risk factors for developing cervical cancer. Remember, we said that human papillomavirus is sexually transmitted. So all women who have had sexual intercourse are at risk. In fact, it's even safer to assume that all of them actually are already infected with human papillomavirus. And the risks are the following: early sexual debut, multiple sexual partners, HIV itself, or other sexually transmitted infection, or even other things that cause immunosuppression. Smoking is another risk factor. Then, briefly, I'll take you through the epidemiology of cervical cancer in Zambia, and we'll begin with a poll question. So I don't know how somebody will do it here.
So we'll allow you to take a breather. What is the incidence of cervical cancer in Zambia? This is a single choice answer. What is the incidence of cervical cancer in Zambia? Is it 75.2 per 100,000? Is it B, 68.5 per 100,000? Is it C, 66.4 per 100,000? Is it D, 59.5 per 100,000? What is the incidence of cervical cancer in Zambia? This is a very interesting, and it can be difficult because for this one, it's either you know or you don't. So it's a very interesting voting pattern, Dr. Quagy. I'll share with you the results in a few seconds. What is the incidence of cervical cancer in Zambia? Is it very high at 75.2 per 100,000, high at 68.5 per 100,000, quite high at 66.4 per 100,000, or 59.5 per 100,000 women? I will end this poll and just share the results. So, okay, someone has even typed in that they think it's B. I'll be interested to know the answer. So most people actually think it's very high at 75.2 per 100,000. I'll stop sharing. You can go ahead, Dr. Quagy. Dr. Siamalambwa.
Oh, okay, thank you very much. Okay. So we'll talk about the incidence of cervical cancer. I'm sure most of you will be able to see the answer. So the incidence of cervical cancer and cervical precancerous lesions is about 6 times higher in women that are HIV positive compared to those that do not have HIV. So the cervical cancer burden in Zambia is one of the highest, which stands at 66.4 per 100,000 in sub-Saharan Africa, with the high epidemic of HIV, which escalates the cases of cervical cancer itself and precancerous lesions that may eventually lead to cervical cancer itself. If you are unfortunate, you might end up dying. So, according to the Global Can report of 2018, states that about 3,000 new cases of cervical cancer are seen every year in Zambia. Over 1,800 women from cervical die from cervical cancer in Zambia. That's a very huge number. Some of them are relatives. I think all of us, we know 1 or 2 people that would have died from cervical cancer. That's 2,000. Remember, we are not many in Zambia. So about 2,000 women die every year. That's quite very high. So according to the Zambia National Cancer Registry, it says that cervical cancer accounts for about 24.8% of all new cancer cases in the adult population that are registered annually. Those of you that have passed through Cancer Disease Hospital, we know very well that it is actually higher than 24.8%, but this is according to the Zambia National Cancer Registry. We know, but inside our hearts, I would say we know that it's more than 30% actually. So that's a global map showing you the incidence of cervical cancer. And we know our friends that are able to do things slightly better. You know, the Canadians, the Americans, you know, the people from New Zealand, some parts of China, and some of our friends within Africa on the northern part, they're in blue here. So blue shows you areas that have an incidence of cervical cancer that is less than 7.4. They're doing very well. Then, you know, the way things are, Zambia is one of the highest. So let's see what color Zambia is in. I don't know if that is the red or orange or reddish orange. That's where Zambia is. So Zambia is among the countries that have a high incidence of cervical cancer that is more than 20 per 100,000. Remember, we said Zambia is at 66.4%. Then, surprisingly enough, our neighbors here, Namibia, they have a lower incidence of cervical cancer, 7.4 to 12.8. So that's the table showing you the top 10 countries in terms of cervical cancer burden. And you can see Zambia is in bold there. It's for number 3 with an incidence of 66.4. And Swaziland is topping. It's around 75.3. But I remember some time back, Malawi used to be at 75, but they have reduced their incidence to somewhere 72.9. I remember at some point, Zambia was at 68.5, but the current one, actually, we have managed to reduce it to 66.4. Okay, so we hope to reduce it further. Okay. Then I'll pause again here. Over to you, Sombo.
The second poll question, secondary cervical cancer prevention, this is for women over 30 years, focuses on the following except A, screening, B, treatment, C, vaccine. Please, let's go ahead and vote. Remember, there is primary, so you want to think about what's in primary. And then there is secondary. You want to think about it as for people that are above 30. And then there is tertiary. This is for all age groups, okay? I won't mention the age group for primary prevention because it may give away the answer. Secondary cervical cancer prevention focuses on the following except A, screening, B, treatment, C, vaccination. You have to sort of think through this. But a very interesting voting pattern. We are taking notes. Some people are voting in the chat box. In the interest of time, I will end this poll and share what people think for now, so that when Dr. Siamalambwa gets to it, he knows where to emphasize. So actually, most people think that it's actually vaccination. Some people feel that it's the screening piece, others feel it's the treatment. You can go ahead, Dr. Quagy.
Okay, thank you. Okay, yeah, so I'm going ahead. So,
What about that?
So we'll talk about cervical cancer over the life course. Of course, we emphasize more on the prevention. Like Kisombo already started preempting my presentation. Okay, so the first thing that I'll talk about is the primary prevention. Remember, on average in Zambia, most of the girls start having sex around the age of 15. Most of the girls start having sex around the age of 15, and that's when they get the HPV infection. You can see it's in red. Remember, we said that young sexual debut is a risk for HPV infection. And then how do you prevent these girls from getting an infection? So before they start having sex at the age of 15, you would want to, number one, vaccinate them. You know, vaccination will prevent them from getting the HPV infection. So the target is girls that are aged between the age of 9 and 13. Then for boys and girls, as appropriate, health information and warnings about tobacco use is very, very important. Remember, smoking is one of the risk factors. Then sexuality education tailored to age and culture. Early sexual debut is a risk factor. So therefore, sexual education is very, very important. Then the other primary prevention method you can use is the condom promotion. But you really need to emphasize that a condom only provides some protection. Then male circumcision as well provides only some protection. So the best method for primary prevention is actually HPV vaccination. Okay, for girls that are not yet sexually active. But how about those? Remember that is that everyone that is sexually active or anyone that has had any sexual contact before, there are some things that they already mentioned. When somebody started having sex at the age of 15, the reason is simple. We said HPV is a weak virus, and it takes a long time to cause cervical cancer, about 10 to 15 years. Therefore, by the time they are 30, that's the time they'll start having, precancerous lesions. So, so how do you prevent them? There are methods that we call screen and treat using a VIA technology, vision inspection with acetic acid. For those that you find they have lesions, you treat those precancerous lesions, preventing them from getting cervical cancer. So for those, then the other method that you can use is looking for the high risk human papillomavirus itself. Okay, so I think in Zambia, those are the two methods that we've been using. And we know the commonest high-risk types of human papillomavirus are type 16 and 18. But we know that there are many others, about 30 of them, or 20 of them, sorry. Yeah. Then we tertiary prevention, meaning somebody already has cervical cancer. So I mean, you have to prevent them from dying. You treat radiotherapy, or you can give chemotherapy. So those are the methods that we use for tertiary, prevention, which we don't want to get to. Then, I'm sure most of you have seen this picture before, or slide before, which talks mainly about cervical cancer elimination. Like, when do you say you have eliminated cervical cancer? You can only say that if the incidence of cervical cancer reduces to less than 4 cases per 100,000 women years. And most of us, we have heard about the Sustainable Development 2030. And these are meant to eliminate cervical cancer. And for you to achieve that, you would want to have the girls to a high performance test such as Hpv DNA testing by the time they are aged in between 35 and 45 years of age. And then for those who come for secondary screening, who find that they've got lesions or they already have cancer, you need to identify 90% of them, and this 90%, they should be put on treatment for either precancerous lesions or invasive cancer itself. Then we'll move on, talk about cervical cancer screening. So what is screening? It's simple. Screening implies testing of a population without symptoms of a disease. It can be any disease. You can screen for TB, but today we are talking about screening for cervical cancer. It identifies those at higher risk of developing a disease, like you will see later on. So for screening to be worthwhile, effective treatment must exist, and it has to be available. I remember in those days in the 80s where people learned about HIV. They were trying to promote against people contracting HIV, but they were showing a debate like it has caught you. Because that time people could diagnose HIV, but there was no treatment for HIV. That's why we are saying now for screening to be worthwhile, effective treatment must exist, and it has to be available wherever you are. So for our environment, what screening methods are there to detect precancerous lesions? Remember, when you are talking about precancerous lesions, you are talking about cervical intraepithelial neoplasia or precancer lesions of cervical cancer. Precancerous before it becomes cancer. So the commonest method that we are actually using in our environment is visual inspection with acetic acid. But we know we have our friends in other countries that use what you call it, visual inspection with Lugos iodine. For us, we use acetic acid. Then the other method that we have started using recently is looking for the virus itself, the human papilloma, the high-risk virus, the human papillomavirus. The other one is Pap Smear. Pap Smear, it has been in existence for a long time, and you know that once you do a Pap Smear, you need to do cytology. So we'll begin with the visual inspection with acetic acid, VIA. So VIA is visual examination of the ectocervix the transformation zone and the cervical os with the naked eye after applying some acetic acid on the cervix. And I don't want to confuse you, and I must emphasize to you that for us, our program Zambia, we're using what we call, it's VIA, but we are using what we call enhanced digital imaging, where camera better than using a naked eye. It allows identification of acetoid areas that need further management. So the VIA itself, how does it work? So abnormal epithelial tissue, especially CIN, turns white after the application of acetic acid. And this turning of white is called aceto white reaction. So when you talk about an aceto white reaction, you are referring to the whitening of an area of the cervical epithelium when the tissue reacts to 3 to 5% acetic acid. The 3 to 5 color is vinegar, not that one which looks brownish, no, but the colorless one. If you want, you can say white the way we used to say it when we were young. So this reaction is caused by the coagulation of cellular proteins which appear opaque when you apply acetic acid. Remember that abnormal cells have a lot of proteins. Remember, they are dividing fast, and there's a lot of proteins. So those are the proteins that coagulate. When they coagulate after applying acetic acid, they tend to look opaque. So for us, we take advantage to identify those precancerous lesions. So when you perform a VIA, how do you report? So VIA, there are only 3 things that you can report on. It can either be it's VIA negative, VIA positive, meaning the aceto white regions present, or it can be suspicious for cancer. I remember some time back, we used to say there was another one called that indeterminate. Now we no longer talk about those things that are indeterminate. There are just 3 possible results: negative, positive, and suspicious for cancer. If you are not very sure, even after consultations, you are better off reporting it as a positive. It is better to overtreat than to undertreat. You overtreat, you prevent a cancer. You undertreat, you will not prevent some cancers. So just a brief review of VIA categories. When you say it's a VIA negative, what do you mean? What we mean is that there are no acetoid area or pale acetoid area that may or may not abut the squamo-columnar junction. Positive, you say, is positive when there are dense acetoid area with sharp borders or with definite margins that may abut the squamo-columnar junction. Then the third result said it's suspicious for cancer. When do you say suspicious for cancer? When you see a mass with irregular surface with or without mucosal bleeding. That's just a summary. So I've put a picture here showing you a VIA negative result. With these, I hope you are able to see my case. These are Nabothean follicles, which are very normal actually. You find them in the transformation zone. So even if you see Nabothean follicles, it's still a VIA negative. Then this is another VIA negative where there's a mucus plug. But remember, whenever you see a mucus plug, you need to remove it because you may not know there might be a lesion here. But for the parts that we're able to see, there's no lesion here. So this is a VIA negative. Another VIA negative, just showing you some streaking. Okay, these are the streaks that I'm talking about, but these do not fit in the definition or in the description of an acetoid lesion for you to say it's a VIA positive. This is a very clear picture showing you a VIA positive. This is a lesion. You can see it has definite margins. Definite margins. Whenever you see a lesion, you have to look at the size of the lesion. You have to look at the location. It's located in the transformation zone, and it's actually abutting the squamous junction, which is somewhere here, and the lesion itself is disappearing into the os. So description is very, very important because it will help you decide what kind of treatment you are going to give. Because whenever you have a VIA positive result, you need to treat. Another picture showing you a VIA result, a positive VIA result. I know you can see some aceto whitening, but remember we said the margins need to be sharp and they need to be definite. If you give a child a pencil, they should be able to draw the lesion. The lesion is here. It's just a small lesion here. It's a small lesion, which is in just 1/4 of the cervix, but I'm not seeing the inner extent into the into cervical canal. So I would say this lesion is appearing into the os. Later on, you'll see the importance of all those descriptions. Then another VIA positive result showing you there's a polyp with the center, but there are these lesions with definite margins, with sharp margins, which you can actually follow. And it's occupying all around the cervix here in the squamocolumnar junction. Squamocolumnar junction is part of the columnar epithelium. Then that's just a picture showing you suspicious for cancer. It's suspicious for cancer. I like saying when you see a chin-to-chin, which you cannot nicely describe, then just report it as suspicious for cancer. It does not look healthy at all. Another one, another chin-to-chin, something abnormal. This is a cervix. This is suspicious for cancer. We are saying suspicious for cancer because you need to confirm it with the histopathology. In such cases, you need to refer them to a doctor who will get a biopsy and send the sample to the histology lab for reporting. Then when you get the report, you change now, you say confirmed cancer. Then I think it is very, very important for me to take you through the national VIA screening algorithm for women that are HIV negative. The difference is very small with those that are HIV positive. Remember, we are saying you do the VIA here. When you do the VIA, there are only 3 possible results. VIA negative, for those that test negative, they come back. Remember, these are HIV negative women. They come back, this is a mistake, they should come back after 3 years. That's the current algorithm. They should come back after 3 years for screening again. Then I'll skip positive, I'll come back to it. For those that are suspicious for cancer, those they need a biopsy. Therefore, you need to refer them to a doctor who will get a biopsy, send it to the lab, and they will have a diagnosis, and then you send them for treatment. Then you have the VIA positive, the third result. When you have a VIA positive, you need to open your eyes. You need to assess that, is it eligible for treatment with cryotherapy or is it eligible for treatment with LEAP? You will see later on the indications. After you treat them with either Abrative Therapy, which is cryotherapy and thermocoagulation, or you treat them with LEAP, they need to come back after 1 year for post-treatment follow-up. Remember, these are the current guidelines. Then for the VIA negative, for women living with HIV, there's only one difference. Actually, the one difference that is there is the rescreen. When do you rescreen them? You rescreen them after 2 years. HIV negative after 3 years. HIV positive after 2 years. Then the rest of the stuff is the same. Okay. Again, I'll pause here. Over to you.
Thank you so much, Dr. Quagy. This is our third poll question. Is this statement true or false? VIA is the best screening method for a post-menopausal woman without a visible squamocolumnar junction. Is this statement true or false? VIA is the best screening method for a post-menopausal woman with no visible squamocolumnar junction. Is this true or false? Wow. People just voted and it was 50-50, Dr. Quagy. VIA is the best screening method for a post-menopausal woman with no visible squamocolumnar junction. Another very good question. I'll give it just a few seconds in the interest of time so that we go in our breakout rooms. What do people think? Is VIA the best screening method for a post-menopausal woman without a visible squamocolumnar junction? I'll end the poll and I'll share the voting pattern with you, Dr. Quagy. Okay, please go ahead with the didactic. You can go ahead, Dr. Quagy.
Okay, thank you very much. That was interesting indeed. Okay. Remember, I talked about VIA, and I said I will show you, like, when you have a VIA positive, which one, how do you decide, like, you treat with the cryo therapy? So the title is a mistake. This is indication for ablative therapy, either cryotherapy or thermocoagulation. If the lesion is less than 75% of the surface area of the cervix, you treat with cryotherapy. If the squamocolumnar junction is fully seen, you treat with the cryotherapy. Remember, whenever I'm saying cryotherapy, if you want, you can replace it with thermocoagulation. Where there should be no suspicion for cancer, then you have to see the whole lesion. If it's appearing into the canal, please, you cannot, even no matter how small the lesion is, you cannot treat it using cryotherapy. Just a bit about ablative therapy. Cryotherapy uses carbon dioxide or nitrous oxide to freeze the cervix. You freeze the cervix, then those abnormal cells die and they slough off. Then thermocoagulation uses heat. It uses about 100 degrees of heat to burn the abnormal cells. And the pictures on the right, this is showing you a cryotherapy gun. And this is another picture showing you how the cervix looks like after you have treated with the thermocoagulation or with cryotherapy. Then when you treat using these two methods are very effective. The cure rates are more than 90%. And the infection rates are very, very low. On less than 1% end up getting an infection. And you must know that the treatment does not cause any problems with future fertility. Then the treatment methods are highly acceptable, and these treatment methods are cheap. Then these treatment methods do not need doctors to treat or clinical officers. The nurses themselves can treat. Okay. Then now I will briefly talk about the loop electrosurgical excision procedure, which is the other treatment method for VIA positive. The other better term to use is large loop excision of the transformation zone. So this is a simple method. It's an outpatient procedure that uses a thin wire loop heated with electricity to exercise the abnormal tissue of the cell. It uses the same normal, what do you call it? Okay, I'll just say lip machine. Then the challenge with this method is that it requires trained staff. Then wherever you're using this method, a theater needs to be nearby. And the blood should be somewhere within your reach, because the cervix can bleed. Even if bleeding complication rate is very, very low, it's actually less than 3%. So you don't need to to worry. It's a very safe method to treat large lesions that need this treatment method. So what are the indications? Lesions that are huge, that cover more than 75% of the cervix. Then those lesions that are disappearing into the endocervical canal, because you don't know how deep they would have gone into the endocervical canal, therefore you might need to cut using LIP. Punctations, mosaicisms are typical blood vessels usually. Lesions that are too thick for cryotherapy or thermocoagulation, you might want to use LIP. You can see this large lesion is covering more than 5% of the cervix. You can't see how far it's going into the endocervical canal, and you can even see the thickness. So for these, you would want to use LIP or LASE. So remember I said nowadays we have started testing, screening using HPV DNA testing. So I should talk about it. It's a test that is done to detect the high-risk types of HPV. The quality is good. The test is accurate and reproducible, meaning it tells you the result is negative. You do it again, it will come out negative. It's positive, you do it again. That's what we mean by reproducible. Then the sensitivity is high, it's over 90%. But if you use a gene expert machine, it's nearly 100%. So when we are saying sensitivity, we are simply talking about possibilities of the actual disease being there. Then specificity, if the result comes out negative, how true is it that it's a true negative? Chances are 81 to 90%. This is very high as well. Then reproducibility, it's more than 95%. So one round of HPV screening linked with treatment can reduce cervical cancer incidence by about 41 to 53%. Remember, we would want to target women that are around the age of 30 to 45 or 35 to 45. So it has the potential for improved coverage because women can collect the specimen themselves. Then there's improved efficiency with self-collection. Fewer women need to undergo speculum examination. Then it has the ability to scale up and meet the needs that are available in our environment. So the HPV results are just two. It's either it's the HPV positive or it's HPV negative, no any other result. So I'll quickly take you through the algorithm for HIV positive women. So you do the HPV test here. We said there are only two possible results. You have an HPV negative. If the HPV test comes out negative, using the current guidelines, you need to rescreen these HIV positive women after 3 years. You rescreen them after 3 years. And remember, this is where the difference is with HIV negative women. HIV negative women, after 5 years, I'll say it in advance, after 5 years for those without HIV. Then for those that test positive, remember they're the ones that might actually have lesions. So when you do an HPV test, remember the majority of the people are able to clear the HPV infection. Therefore, you'd want to identify those that have lesions and decide what treatment method you are going to use. So you need to do a VIA, or you need to do a visual assessment for treatment. Visual assessment for treatment. So when you do VIA, it's the same usual results, the 3 results. Say they're suspicious for cancer, VIA positive or VIA negative. It's VIA negative. For those that tested positive for HPV, if you started with the HPV test, you rescreen them using VIA after 1 year. For those that test VIA positive, you will need to treat them just like you treat, you will need to follow the other algorithm where for those eligible for cryotherapy, you treat them with cryotherapy. Those eligible for LIP, you treat them with the LIP. Those with suspicious for cancer, you refer them for a diagnostic test, a biopsy, then histology. Then HIV negative, I've already talked about. The only difference is here, there is screening after 5 years. So I've already started talking about visual assessment for treatment. What is it? visual assessment of the cervix for treatment for women that test positive for HPV. Essentially, VIA to determine what type of treatment the woman should be offered. All women testing HPV positive and test negative for VIA will be screened after using a 1 year using VIA. I've already talked about most of the things. Then the last screening method that I'll talk about is the Pap Smear. Very, very important. It still has a role. We are not using that much. It still has a role. However, it is routinely used for post-treatment screening follow-up at cancer diseases hospital. Those women that you find have HIV or they have cancer, you treat them with chemoradiation. Then the follow-ups, every year you start doing Pap smears to see, to look out for recurrence of the cancer. Then it is the best method for screening postmenopausal women whose squamous junction is not visible on the speculum examination. It is the best method, not VIA. Remember, if you cannot see the squamous junction, you cannot use VIA, because lesions usually are found somewhere near the squamous junction. For postmenopausal women, usually the squamous junction disappears into the endocervical canal. So if you apply acetic acid there, you cannot conclude that a woman is VIA negative, because you are not able to see where the squamous junction is. So that's just a picture showing you how the cervix of a young woman looks like in adolescent. Part of the ectocervix is the columnar epithelium. The squamous junction is here. Then in post-adolescent women, the part of the cervix changes. It undergoes metaplasia. The columnar epithelium becomes squamous epithelium. That is metaplasia. Then as the woman ages, the transformation zone, this black one is called the transformation zone because it changed from being columnar into becoming squamous epithelium. It retracts into the endocervical canal. So if you apply acetic acid here, this columnar junction is here, how are you going to see it? So therefore, VIA is not the best screening method, but Pap smear is the best method. As you can see, these are the brushes that you use to correct squams from the cervix to send for cytology. You can see the first one here, an endocervical brush. You can use this. You push it into the endocervix, you get some squams, then you send them for cytology. You can also use this plastic brush, which you get some squams from the ectocervix, and part of it will get some squams from the endocervix. Therefore, it makes Pap smear the best method to screen women that are postmenopausal and you are not able to see the squamous junction. Remember, I'm saying the postmenopausal and you are not able to see squamous, because there are those women, maybe they're 1 year postmenopausal. You put a speculum there, you'll still be able to see the squamous junction. Therefore, those would qualify to be screened with VIA. That was my last slide, and those are my acknowledgements. And there's that special acknowledgement to Dr. Omega Chituo from CDC because of a few of the slides that I've presented were prepared by her. Thank you very much. Over to you, Dr. Sombo.
Thank you so much, Dr. Siamalambwa. Before we ask any questions, we'll allow the network. Okay, I see you already have a lot of questions, but I'm sure you've seen, we've sent you an emoji. We are clapping here with the IT guys, and they say you are such a good teacher. They were able to follow everything you said, and you went through those slides very quickly, but very, very clearly. We appreciate that. So I'll allow Matthews to ask his question. Matthews Ndandanda, before we do the poll questions again. Matthews, please go ahead.
Good afternoon, Doc.
Good afternoon.
My question is simple. How would you grade the cervical cancer according to the pictures that we're seeing during screening, I mean, would you able to define or determine what stage the cancer has reached? Thank you.
Before you answer that, Dr. Quagy, you allow Mercy to ask a question and Kawe. So Mercy, go ahead.
Good afternoon, Doc. Good afternoon, Doc. My question comes in where the DNA testing. I was following, you said for HIV negative women, they come back for review after 5 years. How about HIV positive women? Are they still maintaining the 2 years? Thank you.
Thank you, Mercy. Kawe, go ahead and ask.
Good afternoon. Trying to find out on the Hpv testing. On the algorithms, I think the doc had mentioned that when you find that the Hpv is positive, you follow the treatment guidelines to do the VRA, and then
For some reason, Kawe, we can't hear you anymore. You were very clear prior, but you're not clear anymore. You're actually on mute now. Kawe, I'm asking you to unmute. Please click the signal I've sent. Kawe. Okay, Kawe is struggling. I'll allow Dr. Quagy.
You can get me now?
Yes, you were saying that after you do HPV and it's positive, you're supposed to do a VIA. Please proceed.
Yes. On the guidelines there, are there the current ones which we're expecting to see positive? The current guidelines when you do the VIA, regardless of the results that will come out, whether negative and positive, you have to do the abruptive treatment. I don't know if that's the information that we expect, or we're following the same what the doc has just shared with us.
That's very clear. I'm sure Dr. Quagy has gotten it, but I'll go ahead and be brave. I'm not a gynae or a cervical cancer expert, but from what Dr. Quagy said in response to Mercy, when you are doing the HPV, for those that are HIV positive, you now, according to the new guidelines, this is what Dr. Quagy said, you screen them after 3 years if they are HIV positive, but HPV negative. For those that are HIV negative, but HPV negative, it's after 5 years. I believe that's the new thing in the guideline. It's no longer 2 years for the HIV positive. Dr. You can pick up Matthew's question and come.
Okay, I will continue with what you have started answering. Remember, I've put so much emphasis to say.
You can go back to the slide.
Okay. Remember, I was talking about the current guidelines, the guidelines that we're using now. But very soon, maybe I've already started reading, guidelines are going to change. Remember, WHO has changed the guidelines. Do not confuse. We have not yet started using the WHO guidelines, and I do not wish to confuse you. So as soon as we review the WHO guidelines, come up with our own guidelines, we should be able to share them with everyone. So at the moment, these are the guidelines that we are using. Thank you, Dr. Sombo. Then the pictures that I showed you, you cannot stage for cervical cancer. Cervical cancer, remember, the staging is done clinically. You need to assess the vagina. You need to assess the pelvis itself, the parametrium. You need to assess the lungs, the liver. Therefore, using those pictures that are displayed there, you cannot stage cervical cancer. Then on HPV screening, or screening, okay, I've already answered it. Then the guidelines I've already answered it as well. Thank you, Dr. Sombo, over to you.
Thank you very much, Dr. Quagy. Kabwe, I hope that's very clear, Mercy and Matthews, on the guidelines and what you can do, well, via VIA, what you can talk about and what you cannot talk about. There are a few questions here, Dr. Quagy. May you please stop sharing your screen? May you please stop sharing your screen? Thank you. We have a question from Happy Care. He says, the first question is, how responsive is cervical cancer to chemo or radiotherapy when someone starts their treatment in stage 3? Number 2, how are patients who have been successfully treated from cervical cancer followed up? Then ask, when do you rescreen a negative woman who turns positive before the next screening test? Very interesting. Quagy, the questions in the chat.
Okay, I'm trying to see them. I will start with the first one. Maybe that's, stage 3 cancer, how effective is the treatment? The treatment is very, very effective. Actually, from stage 1 up to stage 4A, when you are treating, you are aiming to cure the disease. You are aiming to cure the disease. So the other things that you need to look at when you're talking about the prognosis when it comes to cervical cancer treatment, you look at the lymphovascular space involvement. If there's the lymphovascular space involvement, the prognosis is much poorer compared to another person without lymphovascular space involvement. Then you also look at the I'm trying to look for the actual term. It has slipped off my mind a bit, but I will talk about it. Age as well, you need to look at. So those things I'm mentioning, that we call them prognostic factors when it comes to treatment. 2 people can be in stage 3, but the response to treatment might be different because you need to look at the prognostic indicators. Like, for example, stage 3B, is there hydronephrosis? If there's hydronephrosis, the response is poorer compared to someone in stage 3B without hydronephrosis. I think that's the shortcut I can use. Then the other question, Dr. Sombo, just remind me.
If a woman has been treated for cervical cancer, how do you follow these patients up?
These women are usually followed yearly. I can't remember the actual intervals because these things change. I have not been to Cancer Disease Hospital in a long time. Maybe one of the experts will say, by the time I worked there, it was every year you need to do a Pap Smear to check for recurrence. Once every year you do a Pap Smear. If things have changed, maybe the gynecologist can help out.
Okay, thank you very much. So for those that have cancer, they've been treated, the information we have is actually cytology for those patients. So Dr. Quagy, there's a question here. If a woman was negative, but she turns positive before the next screening test, how do you rescreen them? There's a question from Pima Planga. I get the sense that I've actually missed the question, but maybe you understand it better than me.
Yeah. I think there's just a mix-up. For you to say that I've tested positive, it means that you have screened them again before they're due for the screening. So if they test positive, you decided to screen them earlier before they're due for the screening, you treat them. Anyone who tests positive, you treat using the appropriate method.
Thank you so much. So we are preparing to go into our breakout rooms. I'll allow Chatonda in the next 2 minutes to explain, but there's a question. How do you collect a sample for GeneXpert if you are going to do an HPV test using the GeneXpert platform. I believe you explained it, but some people may not have gotten it. Just in a few seconds, how do you collect a sample to get on a GeneXpert machine?
There are two kinds of specimen collection kits that we have. We have provider, like at the moment, the ones we have, they're supposed to be collected by the provider because the brush has to be pushed in, has to be pushed into the endocervix, don't need to touch the vaginal walls. It doesn't matter whether the testing will be done by the GeneXpert machine or the Logic Panther or PCR machine. It doesn't matter. You can use either methods to test them. Then there's another one which is it can be, a woman can self-correct. That one doesn't matter. It doesn't need a speculum. A woman can push it into her vagina as high as possible till they reach resistance. Then they can rotate the brush about 5 times. So when it comes to testing in the lab, you can use either machine, a PCR machine or a GeneXpert machine. Thank you.
Thank you so much, Dr. Quagy. We are going to share now, but I had a question on the effectiveness of the HPV vaccine. How effective is that vaccine?
The effectiveness, I wish Dr. Chaira is on there. I can't remember the actual figure. I wish Dr. Chaira, I wish one of my colleagues would be able to respond to that.
Okay. Okay. Now we are going to break into the breakout rooms. Remember, the provinces that submitted cases are Luapula, Central, and Chinsali. So if you are coming, for example, from Copperbelt, you will be put in either of these rooms, okay, because we don't have a specific room for you. Chatonda, please go ahead.
Okay, good afternoon, everyone. Okay. Good afternoon, Nitek. Please note that as we break out into the breakout rooms, we are breaking out in the following rooms because these are the rooms that are sharing cases. That is Central Province, Luapula Province, and Muchinga. Please note that as we break into the breakout rooms, you are self-assigning. You can choose which room to join. So as you can see from what I shared there will be a small pop-up that will ask you to join the breakout room, and then you choose the breakout room you prefer. That is Central, Luapula, Muchinga. So the breakout session is 20 minutes, and then we'll then come into the main room just for summarizing. Please feel free to reach out to UTH Hub IT or Chatonda Mvula if you have any questions. You can send me a message in the chat.
That was fantastic. We are now going into our breakout rooms. We'll see you back in about 15 to 20 minutes. Special thanks to the provinces that submitted cases and to the cervical cancer team. That was very, very good.
In terms of the physical examination, that was done on the day of
Put water.
Excuse me, sir. Hello? Hello? Hello?
until about 3 months ago, when the patient was changed to TLD. So on the 2nd of October 2021, which is this year, the HB was 6.9 grams per deciliter. And like I earlier mentioned, the patient was now changed to TLD. On the 6th of October 2021, the creatinine was 89. The HB was 7.3 grams per deciliter. This is after transfusing 1 unit. The viral load at this time we collected the results. It was not detected, so virologically suppressed, and the patient has continued on TLD. On the 9th, or 3 days later, we got results for CD4 count, which is at 523. And then the HB, after receiving 3 more units of whole blood, it is now at 13 grams per deciliter, and the patient has continued on TLD. So our questions.
Maybe at this juncture, thank you, Dr. Banda. I think that was a very detailed summary of the case that he's presenting. At this juncture, Dr. Banda is going to pose some questions to the participants or attendees of this breakout session, and would like people to be freely able to respond to these questions so that we can understand how we can progress or how we may address such scenarios when we meet them in future. You can start with the first question.
Thank you so much, Dr. Kapusa. So our questions, we have got 3 questions today that we want to discuss. I'll read through and then go back to the first ones. So the first one is, as like we have observed from the scenario, from the case, despite virological suppression, this patient had cervical cancer. Is this usual, or does being virologically suppressed mean one has no risk for cervical cancer? I'll repeat, despite virological suppression, this patient had cervical cancer. The question is this unusual, or does being virologically suppressed mean one has no cervical cancer? Question number 2, what are the challenges in the early screening and the detection of cervical cancer that contribute to situations where the disease is only diagnosed when it has progressed? Question number 3, what are some of the best practices we can adopt to improve on early detection of cervical cancer in HIV positive women? So those are the 3 questions, Dr. Kapusa, I submit.
So we can start with the first question. For those that are online and those present in the in-service, what is our response to the first question? Are we surprised that someone with virologic suppression can present with advanced disease? Dr. Chalo. Dr. Chalo has the response? Okay. Dr. Chalo, you may unmute yourself.
Good afternoon, everyone. So looking at the first question, if we're following in the presentation, for patients that test negative for screening, usually the HIV status doesn't really mean you're at low risk of developing cervical cancer. So we just looked at the duration in which maybe the screening has to be done for those that are positive 3 years later, for those that are not positive 5 years later, which means even if you're HIV negative, you still run a risk of having or developing cervical cancer. So in that case, we look at other things that we learned earlier on concerning the early onset of sexual activity, the Hpv vaccination, and all those things. These are things that we need to consider more intensely as opposed to the HIV status of the person. So personally, I think the virological status doesn't necessarily mean if you're suppressed, you have no risk of developing cervical cancer. Please correct me if I'm wrong.
Dr. Banda, you'd like to respond to that?
Thank you so much. I think I totally agree with Dr. Charo. Indeed, being biologically suppressed doesn't mean one can't get cervical cancer, or the risk for getting cervical cancer now they have disappeared. As we learned earlier on from the presentation, that it takes about 10 years to 15 for pre-malignant lesion, VIL, if one acquires HPV infection, for it to be transformed into cancer, it will take about 10 to 15 years. So meaning that even if you are diagnosed with HIV today, even if you are biologically suppressed, you still have a higher chance of developing a cervical cancer.
Can I come in? Okay.
You have a question?
No, this one the addition.
Okay, you can make your contribution.
That's my contribution. I think from our case, we have seen that this woman was HIV positive, and when this patient presented to our facility, at least we could have seen that when the most important question that was asked was the card, the cervical cancer screening card, which she didn't have it. Then on this development of cervical cancer between the 10 to 15 years, in HIV, I think we have to bear in mind that this duration might tend to be quicker in immunosuppressed people. From my experience, I've seen that in HIV patients, cervical cancer tends to progress very fast. And I look forward to the algorithm that we have seen on the follow-up of the 3 years, that maybe in future these might change. We need at least to reduce to follow them quickly, because if you see that you can see a HIV patients in 2 years, and when that patient comes immunosuppressed, you can find that the cancer has progressed. I submit, that's my contribution.
Thank you. So in the interest of time, we'll go to the second question, which was posed. What are the challenges in the early screening and detection of cervical cancer that contributes to situations where the disease is only diagnosed after it has progressed? So if we are able to appreciate this patient was seen in facilities from 3 years ago, but we are only able to receive this patient in the past week with very advanced disease, large tumor detectable on clinical examination, on the scans, and with hydronephrosis, advanced stage. So the question is, was there a problem with the screening? Is there something that was missed? This is the question now that we should pose to ourselves as a province. I don't know if there are any contributions from within this room.
Okay,
You have a contribution?
I have a contribution.
A response to that question?
A response to that question.
You may go ahead.
Yes, yes. I think the challenges that we are facing into our screening sites. This patient was HIV positive, and we have said that cervical cancer has been integrated into ART. Sorry?
You can continue.
Okay, continue. Okay. This patient was HIV positive, and looking at what we have done, we have integrated cervical cancer into our ART clinics. So from the case that we have, it will have been shown that this patient was not being screened or was being emphasized to be screened in our ART clinics. This patient has been getting drugs to in our facilities, but not emphasized about cervical cancer screening. So this is the challenges that I've noticed, and we need to emphasize that every woman who's HIV positive should be screened when the appointment dates for them is arrived. So we should try by all means to integrate and to make everyone know that cervical cancer is part of the service when they come to get our drugs. I submit.
Okay, thank you. We have 2 hands up, but before Dr. Mbambo makes his contribution, there's a submission from the Zambezi District Hospital that from our communities, people have a lot of needs, especially in the villages, and they may only come to the hospital when the disease has progressed. They may not know that early screening is important for early detection. I think that's a very good submission from the Zambezi district, and it's valid even within our province. Dr. Mbambo, if you are ready with your question, you may proceed, or with your addition or response to the question which has been posed.
Thank you, Dr. Kakusa. Thank you, Dr. Banda, for that elaborate presentation. My contribution regarding question 2.
Dr. Mbambo, are you muted? We can't get you. The audio is not okay. So maybe we can respond to Chikoti. Chikoti, you can make your submission.
Okay, thank you so much, Doc. I would have to pick on the third question. I think it would be more nice or more prudent to continue sensitizing to our clients about the importance of cervical cancer screening, the way we've done to VL tests, so that when they come, they should be knowing that after maybe a month, they should undergo cervical cancer screening. Thank you.
Okay, you have jumped though. We are still responding to question 2, but I think your submission is well appreciated. Is Dr. Mbambo still able to give his contribution? No. Okay. Nakazwe. So many hands up.
Just a contribution on question. I think one of the challenges, just like Zambezi has elaborated in the community, it's important that intensive IEC is done in the communities. Especially, we need to involve the community leaders so that IEC can go out, the information can go out there on the importance of cervical cancer screening, especially that cervical cancer is not easily detected in the early stages. So there's need for intensive IEC information to be taken into the community so that more women will be sensitized on the importance of cervical cancer screening so that we can prevent them from coming to the facility only when the disease has advanced. Thank you.
Thank you. I think that was also in response to the third question. Maybe just to go back to the second question, since we have the expert online, Dr. Siamalambwa, our second question on the challenges of early screening and detection of cervical cancer. Is there anything that the co-host is able to share with us, which we can pick up as a province, especially that we were receiving this patient in such an advanced state? I believe there is something that was missed along the way as the patient was being followed up within the health facilities. So what could be done differently about this approach? Is Dr. Siamalambwa able to give an expert opinion on this?
Oh, okay, thank you very much, Dr. Kakusa. You are talking about the second question?
Second question.
In relation to our patient.
Yes.
Yeah. For me, I think that an opportunity was missed when a VIA was done at Chipata the one hospital. I'm sure by then she already had cancer. One thing we need to remember about cervical cancer is that it's not a fast-growing cancer compared to these other cancers, but still in HIV positive women, the progression is much faster, but you can't compare it to other cancers, gyn cancers like choriocarcinoma, which progress very fast. So, sorry, I don't know. Dr. Kakusa.
Oh, sorry. It looks like we are being sent still in the breakout session?
Oh, yeah, I think we are back. Okay.
Okay. Hi, Dr. Quagy. We will at this point allow Dr. Wisdom Banda to give us a summary of the case from Central Province. Then Dr. Siamalambwa will actually conclude for us. Dr. Banda.
Thank you so much. Thank you so much. So, presenting the case for Central Province. So GC, female 44, non-HIV positive since 2018, who came in as a referral from the Teta District Hospital for further management of pelvic mass. With a history of ill health for 12 months, she came in with foul-smelling vaginal discharge for 11 months, loss of weight for 10 months, a vaginal bleeding for 10 months, palpitation for 3 months, lightheadedness for 3 months, easy fatigability for 1 month, constipation for 5 days. The review of system was non-revealing. So in terms of gynecological history, there's a history of VIA in 2020. It should be noted that the patient was having, that was after a 1 month history of postcoital bleeding. And after presenting with that complaint, several scans were done at face level until finally in 2020, which was the scans were non-revealing, and they proceeded with a VIA. Patient was later referred to UTH, where a review date was given, but patient didn't go back to UTH after feeling better. So in terms of past medical history, drug was non-revealing. The drug history was on TLD and hematinics. The sexual history was also non-revealing. The only thing of note is that she resigned as a maid a year ago due to ill health. So in terms of physical examination, when she came in on the first day that we saw her on the 1st of October 2021, the patient was fully conscious, cachexia. She was pale 3+. The lungs were clear clinically. S1 and S2, there was a hemic murmur. So per abdomen, there was a palpable pelvic mass, which was fixed about 14/40. The VE, there was a cervical mass extending to the upper 1/3 of the vagina, and the mass was compressing the rectum with contact bleeding. The investigations that were done, pelvic ultrasound reviewed a cervical mass, which was 6 by 6 centimeters. Of note was that there was bilateral hydronephrosis. The liver, nonetheless, was normal. Biopsy was done, which reviewed invasive squamous cell carcinoma of the cervix. The chest X-ray was normal, and so in terms of diagnosis, it was a cervical cancer stage 3B. Next slide, please. So in terms of the progression of the illness and the results that were obtained, apologies for the dates there. It's 12 September 2019, when the viral load was 0 copies per mil, and the patient was on TLE. On the 10th of September 2020 and not 2021, the viral load was 29 copies per mil, and the patient continued on TLE. So 3 months ago, the patient was switched on TLD. So this was a time that the patient came in on the 2nd of October 2021. The HB at a time was 6.9 grams per deciliter. And 4 days later, the HB was repeated after transfusing a unit, and it was 7.3 grams per deciliter. And the creatinine was at 89. The viral, like Adrian, the viral was done, and the patient was virologically suppressed. On the 9th of October 2021, the CD4 count was 523. The Hb was 13 grams per deciliter. This was after receiving 3 more units of whole blood, and the patient has continued on TLD. Next slide, please. So, so in terms of our questions for today regarding the case, the first question is, despite virological suppression, this patient had cervical cancer. Is this unusual, or does being virologically suppressed mean one has no risk for cervical cancer? The second question is, what are the challenges in the early screening and detection of cervical cancer that contribute to a situation where the disease is only diagnosed when it has progressed? The third question, what are some of the best practices we can adopt to improve on early detection of cervical cancer in HIV positive women? I submit.
Dr. Sobo, again, take it up to. Hello, Dr. Sobo.
Dr. Quagy, please go ahead.
Okay. I know we had very interesting discussions in our Central Province room. I think, like we discussed in the other room, a negative HIV status that does not exclude someone from developing cervical cancer. No, the only difference that are there, getting infected with human papillomavirus, chances are higher, and then the viral infection persisting, chances are higher. Then if the HPV infection persists, chances of somebody developing precancerous lesions, chances are higher. Somebody finally developing cervical cancer, chances are higher, and the progression is much faster than those without HIV. So a negative HIV result does not exclude somebody from getting from developing cervical cancer. It's just that those that are HIV positive, the chances are much higher, about 6 times more. So I think that is the difference. So when it comes to virological suppression, why should somebody still develop cervical cancer? Remember, there's a lot of research still ongoing. But the debate right now is that no, there are some people whose immunity has been improved, they are virologically suppressed, but compared to those without HIV, they still develop cervical cancer more. That's one area where people are still researching to find out why. Then the second one, what are the challenges in the early screening and detection of cervical cancer that contribute to situations where the diagnosis is only diagnosed when it's progressed? I think here you are talking about systems, us who screen women for cervical cancer, where we fail to detect the disease early. So it could be that maybe the people that screened at Chipata level 1 hospital do not know how to screen for cervical cancer. Because I'm wondering how they could miss the lesions, because I don't think it progressed from no precancerous lesions within a year to a cancerous to a stage B, to a stage 3B. I don't think so. The cancer was already there. So it's just about the issues of quality improvement. Wherever she got screened from, people need to look at the challenges they're having, and they need to come up with QI projects so that they can improve on how to detect, precancerous lesions and cancer itself very early when patients come to us. Remember, when patients come to us, we need to help them. We need to have the skill. We need to detect the disease and then treat them. The third question mainly is talking about the people themselves not wanting to to come to us. For the HIV positives, remember, they always come to us for drug pickups. They always come to us for to do maybe at viral load. We need to take advantage at those times when they're coming to us. I'm not so much involved in the HIV programs, but I know that if a patient is due for a drug pickup, community liaison officer calls that particular patient. If it's a woman, they check in the records that have not been screened for cervical cancer. I think we need to start including cervical cancer screening messages in all the HIV messages that we are giving to these women. For example, I guess I know I've noticed that you are due for a drug pickup next month. And the other thing I've noticed is that you have not yet been screened for cervical cancer. We encourage women that
Quagy, we have lost you.
Your HIV status to be screened.
Okay.
Yes. Welcome back. Somebody's calling me. Yeah.
Yeah.
So we need to use all those platforms. If you're a Christian, a patient comes to you, you need to check in their records. If they have not been screened for cervical cancer, you need to connect them to cervical cancer screening. So some of the things we can do ourselves, and some of the things I think the health programs can help us out. I think I went here, Dr. Sombo. Dr. Sombo.
That is a very appropriate ending to that. We want to thank the cervical cancer team once again for their input in this. Just to mention that every Friday, or most Fridays, the cervical cancer program actually breaks this topic down even further. We urge all of us to join. It's on every Friday at 14 hours. Chatonda will be sending through the link for that. As you can see, it's quite a broad topic. Dr. Quagy did a great job of simplifying that. But of course, in terms of learning, you maybe have to listen to a few more sessions for you to become an expert. It is very clear. This is a very preventable malignancy. Ideally, as they are saying, I saw the goal for 2030, no woman should have to suffer the consequences of cervical cancer. We can look for it early enough and prevent progression and screen for HPV. So thank you very much, the cervical cancer team. And most importantly, thank you to the network for joining this very, very important session. We expect at least all women, HIV positive or negative, should get screening at some point in their lives and frequently after that, as per Zambian guidelines. Dr. Quagy, cervical cancer team, thank you very much.